Welcome to the Secour's Richmond Neuroscience Institute Community Awareness on Neuroscience. I'm Pat Lane and I am a Neuroscience Coordinator for Secour Richmond. We are pleased to provide the Community Awareness Show on neuroscience and hope that we provide a wide variety of topics over the next 6 weeks. Let me first just start by saying that tonight we will be taking phone calls between 6:30 and 6:45, and that number to call will be 804-915-5202. Also, if there are questions that we can't answer tonight, please feel free to call us at 804-359-WELL, which is 9355, or please contact us at our website, www.bondsecours.com. Our first show will cover migraines, headaches, pain, and post-concussion syndrome. Oh my, it almost sounds like the Wizard of Oz. Our panel today features from Secour Neurology Clinic. Our first guest is Dr. Stacey Lawrence Epps. Dr. Epps received his undergraduate degree from Virginia Commonwealth University, his Doctor of Medicine from Georgetown University, and then he traveled around the DMV and interned at Inova Fairfax Hospital and completed his residency at Georgetown University Medical Center and Washington Veterans Affairs Medical Center. He is currently the chair of St. Francis Medical Center Neuroscience Department and is a member of Secour's Medical Group Neurology Clinic. In his spare time, Dr. Epps is the vice president of the Virginia Epilepsy Foundation Board, and he is well published and well versed. Thank you, Dr. Epps, for being with us today.
Thanks for having me, Pat.
Our next guest is Dr. Salmaan Khawaja. He is a graduate of Virginia Military Institute. He received both a Master's of Arts in Educational Specialist degree from James Madison University. He went on to complete his doctorate in a unique combined integrated program in clinical and school psychology at JMU. Dr. Khawaja completed an internship at Eastern Virginia Medical School and residency and fellowship in clinical neuropsychology. And he also is a licensed clinical psychologist and neuropsychologist. He provides confidential services, including comprehensive neuropsychological and psychological educational evaluations. Dr. Khawaja is also a member of Secour's Neurology Clinic. Welcome. And last but certainly not least is Dr. Asghar. Dr. Asghar attended the University of Alabama, Birmingham, and from his undergraduate degree. He received his medical degree from the University of South Alabama College of Medicine and completed his neurology residency at the University of South Alabama. Dr. Asghar completed a clinical neurophysiology fellowship at the University of Michigan and pain medicine fellowship at the Medical College of Georgia and Georgia Health Science University. He is a diplomat of the American Boards of Psychiatry, Neurology, and Clinical Neurophysiology, and board eligible in pain medicine. He is the newest member of Secour's Medical Neurology Clinic. I am truly with experts tonight, and they also look very handsome.
Thanks, Pat.
So one of the things that I really want our community to understand in reference to Secour's Neuroscience Institute is that we truly are here to serve. So I want to ask each one of you, why did you really go into your field and your profession? Because I think that's what we offer, a special caring touch. So I'll start with you, Dr. Asghar.
Well, I think the reason I chose to go into neurology was it was the most fascinating part of medicine I could find, and I just think that the potential for treatment of neurologic disease is open-ended, whereas we may have reached some limit or pretty significant progress in most fields. I think in neurology, we're just kind of at the beginning of it, and I just wanted to be part of that development.
Okay, thanks. How about you, Dr. Khawaja? I mean, you have a wonderful history in neuropsych, and that's different.
Well, I've always been, I've always been interested in the brain. I mean, we call the brain the uncharted universe. And ever since a young child, I always wanted to be a doctor of something. And then in college, when I was at VMI, 9/11 happened. And after 9/11, I became very interested in what makes people tick and what makes people do the things that they do. And it's an interesting intersection between understanding brain and behavior that I find really, really fascinating. And I think it's a nice niche that really fits my personal, cultural, and professional development goals really, really well.
Great. We're going to get into that tonight a little bit more because it's fascinating. And Dr. Epps, what about you?
Well, my experience at Georgetown was one where Georgetown had a very strong Department of Neurology. In fact, if you look at most medical schools across the country, they send one or maybe two people into neurology residencies. Georgetown consistently would send 6 to 7 every year. So the program was very strong. So we had a lot of good teaching, a lot of enthusiasm in that department, which was contagious. I think the moment that I really decided I wanted to go into neurology was the first time as a fourth-year student that I took care of a patient in status all by myself. There were people there if I needed it, but it was just stimulating and it was fascinating. So that's what bit me.
Great. So I think that when people hear neuroscience, I'm not sure they really understand what neuroscience is. So I'm going to ask you all to really break it down for our community of understanding. I know we only have an hour show because I have the three of you on. I know we could be up here for days talking about that. But let's try to break it down, if you can, Dr. Epps, into what we want the community to know about neuroscience so they know the right actions to even start with.
Right. So in its most basic sense, neuroscience is the study, treatment of diseases of the nervous system, care of people with nervous system diseases. The most common things that people will encounter are headache, which we're going to speak about tonight, various types of headache, Alzheimer's disease, and other dementias. The thing is that people think that all dementia is Alzheimer's, and dementia is a catch-all, and it's very important to discern what type of dementia a patient has. Things like multiple sclerosis, things like peripheral neuropathy or nerve damage due to other metabolic diseases such as diabetes, such as having had chemotherapy from cancer. It ranges up into care of seizures and epilepsy, people with brain tumors, which we care for in conjunction with our neurosurgery colleagues. You get into Dr. Khawaja's area of neuropsychology. What is the function of the brain? I can look at the anatomy and the physiology, but how is that brain functioning in terms of day-to-day life? Where are the problems? You look at Dr. Asghar and pain management. Pain is mediated through the nervous system. That doesn't mean that every type of pain is neurologically based, but the nervous system can be manipulated in order to help control that. So in a sense, it basically is anything that has to deal with the nervous system.
Great. So I'm going to now break up from what you said to the two of you, and I'm going to start first with you, Dr. Khawaja. Mm-hmm. How do you complement neurology? We are very happy to have you here because function of the brain is, that's what it's all about. So if you can tell us how you complement it, how you work, how do you get referrals, or how somebody would even come to you, that would be great.
Sure. The interesting thing, about neuropsychology is that most people don't know that we exist until you actually need us. Mm-hmm. And what neuropsychology does is we're at the intersection of psychiatry and neurology. In other words, what we look at is how someone's thinking, attention, concentration, memory, learning, focus, motor skills, and all those sort of day-to-day life applications are impacted by a variety of neurologic or psychiatric or both conditions. So, for example, we started about age 5 and we work our way up the age spectrum. A parent might want to know Does my child have an autism spectrum condition? Do they have ADD or ADHD? Or why are the behaviors that are happening? Mm-hmm. If there's oppositional behavior or some sort of other problematic behavior that's going on, we can help better understand what's going on. And as that person grows into adulthood, we can look at things like traumatic brain injuries, impact of concussions, car accidents, and things like that, and see how does that impact our day-to-day life. In other words, how does a neurologic condition translate into what we do on a daily basis? Do we have problems with our thinking or attention? Can we function at work? If we had a concussion or some issue like that, how might that impact our academic performance or things like that? And as we go up throughout the age spectrum, the question always becomes, does my loved one, does my parent, or does my spouse have early signs of dementia or memory loss that's not associated with normal aging or other medical conditions? And one of the only ways you can determine whether or not there is a condition going on and identify it very early is by doing neuropsychological testing. And early intervention is so key in preventing or at least slowing down the progression of a disease that's absolutely a very progressive and debilitating condition. So we can help neurology in a lot of different ways, and psychiatry and general practice, in terms of understanding what specifically is going on and how does that translate into our day-to-day life.
Fabulous. And Dr. Asghar, your specialty is pain. And I really want to understand this about pain. What causes us to feel pain? Is it the brain that feels pain? I think Dr. Epps kind of alluded that. And how do you define pain?
Okay, so we'll start out by talking about what is pain. So pain is not always abnormal or bad. Pain is a natural response to injury or potential injury in your body. So so the things that cause pain are when you have abnormal injury to the nerves or injury to the muscles or tissues, and your nervous system pathways and nerves transmits that through your spinal cord into your brain, and it's in your brain where it's sorted out as to if that's a normal response or an abnormal response. So whereas the brain itself doesn't feel pain, it's the translation of the sensations that are that we feel as pain.
Okay. So now what's the difference between chronic pain, there's so many types of pain,
Sure.
neuropathic pain, acute pain, and then I've heard of this phantom pain.
Okay. Well, I think the easiest way to start is to understand, the difference between, acute and chronic pain. So in sensory-wise, they're the same. There's no difference between them. The real difference between chronic and acute pain is the duration. So whereas we, as a medical community, basically agree that acute pain is pain that lasts up to 4 or 6 weeks and is, maybe related to a certain injury, chronic pain is pain that doesn't go away and lasts greater than 3 months. So, we can all have acute pain from, injuring our back, but that may go away and you may never have chronic pain. But, once you end up with chronic pain, there are treatments we can do to try to help reduce the impact of that.
Okay. And in healthcare we have.
I'm sorry.
Go ahead.
No, I didn't. I'm sorry,
Okay.
I didn't finish. But neuropathic pain is pain that's specifically related to the nervous system, but pain that is has a specific character: burning, shooting, stabbing, throbbing, electric-like pain. That's the type of pain people with neuropathies have, or specific nerve injuries. People have, a common condition called sciatica, or irritation of the sciatic nerve. So that would be a type of neuropathic pain. And for the last part, phantom pain is pain that's associated with a limb that you've lost. For people who've had an amputation, they feel as though the limb is still there. And they tend to have nerve or neuropathic pain in that extremity which doesn't exist, but they feel as though it does.
Okay, great. And thank you for reminding me, because I could be in depth forever.
That's fine.
I know that's your specialty, so I
No.
definitely want you to end. But in healthcare, I want the community to know we actually have our own special language. We have, and neuroscience just takes it to a whole nother level when we're talking about that. But I also want to talk to you about that. There's terms like myalgia, arthralgia, neuralgia, and I bet our callers will call about fibromyalgia is what we had talked about before. So what are we talking about when we're talking about this type of pain?
Okay. So myalgia pain is myalgia generally relates to muscles, okay?
Okay.
So myalgia pain is pain where people feel aching, chronic throbbing, aching pains in the muscles. And, as neurologists, we kind of fit in by helping sort out, is the pain related to inflammation of the muscles, or is there no inflammation of the muscles, and, what context to put it in. In terms of arthralgias, that would be more pain related to the joints, pain of the knees, the elbows, the ankles, and for example, could be, arthritic type pain. Mm-hmm. And so that's a little different than myalgias. And then neuralgias essentially relates to pain that has a neuropathic component, burning, tingling, sharp stabbing, as it relates to a single nerve or multiple nerves.
Okay. So now that you've given us kind of your quick overview of pain, what type of pain should someone come to see you for? And can you give us some type of treatments? As I walk into CVS or Walgreens, they're like lines of things for pain. So what do we do?
Well, I mean, I think, in general, we like to start out with conservative care. I don't think anyone needs to jump to the end of the line treatment. But the types of pain that I would personally see or take care of would be back pain, neck pain, hip pain, shoulder pain, and with the rest of the other neurologists, we deal with headache. And I think things that would be important to do, or things I would consider treating with, would be referrals to therapy, non-invasive treatments like things called a TENS unit, which can be helpful, and it's not a medication. And then kind of slowly, looking at non-narcotic medications and helping patients out to maximize their function. And if those things aren't effective, then we can get into a little more minimally invasive treatments, such as injections and radiofrequency treatments, and very specific things to help with chronic pain if that's the issue.
Okay. And this is National Rehab Week as well. And tomorrow at MRMC, which is Memorial in Hanover, Sheltering Arms is actually going to show some of those demonstrations of what to do with exercise and rehab and TENS unit and how that can help as well. So I just want to shout out that, and that's free, everybody, from 4 to 6 tomorrow. So you can go out there with your family, and they're going to have food and fun and demonstration of what you can do. Now, Dr. Khawaja, as a neuropsychologist, do you treat any type of pain? And if so, what types, or how would that referral come into you, and what will happen with that?
Well, like Dr. Asghar was talking about, chronic pain, acute pain, and the various types of pain can be caused for a variety of different reasons, but there's almost always a psychological component to pain.
Okay.
If we're constantly hurting, if we're constantly numb, tingling, we're having the different things that he was discussing, there's going to be an impact on how it is that we feel on a day-to-day life. It's going to impact our emotion. And in some ways, it will impact our thinking and our concentration and our learning and our memory too, because the mind in some ways is distracted by the fact that we don't feel well, and we don't feel well all the time. So a neuropsychological evaluation can help determine, well, is there actually something going on in the brain that's impacting memory, or is this a pain-related issue? And if so, what do we do about it, and how can we help? So sometimes these evaluations can really help in delineating between those two things. But in addition, it can provide the emotional support, the psychological support in dealing with patients who have intractable pain, or who are dealing with those sorts of issues. So either way, it can help determine what's going on in the brain, and what do we do about the emotional impact and the psychological impact in general that pain does to the body.
And in the clinic, are you all working with the families as well? Do we have that as of yet? I'll turn that over to you, Dr. Epps. What are some things that you have seen or thinking about as you're expanding? I know you might want to do that now and talk about that area.
We are expanding. The Secour Medical Group Neurology Clinic has had overwhelming support from the community. We started about 3 years ago with 2 docs and a couple ladies in the office, and we're actually opening 2 new offices, one October 1st at Memorial Regional Medical Center, which will be a 4 neurologists, 1 nurse practitioner practice. We're opening up our Watkins Center office October 15th, which will have an embedded neurodiagnostic center in that, so that basically if a patient comes to see us, we can do all of the diagnostic testing right there in one place. With that, we will be transitioning our Iron Bridge office with Dr. Asghar into a neuroscience center for pain, so that a patient can come see Dr. Asghar and get whatever invasive treatments or minimally invasive treatments, such as injections, radiofrequency ablations, the other modalities he mentioned, right there in one location. So that's all coming. In terms of dealing with the family, it's a little bit of a tricky situation sometimes, because you have to get the consent of the patient to bring the family in. And sometimes, depending on what's going on with the patient, the family may not be the best source of support. We like to think that our families are very supportive. Sometimes they actually may be a source of stress. It depends on what the dynamic is. And I think that's where working with Dr. Khawaja helps uncover that, because with pain, with migraine, with other issues, what are the stressors that are driving this? And if you don't identify those, you can't treat them. And if you don't treat them, the condition stagnates and you won't get better. So that what we're looking to do, particularly at Watkins, is develop in the area of headache, a comprehensive headache treatment center, which is not just come on in and get your regular pill or maybe get some Botox. Yes, those are going to be available because they're important. But what we want to do is actually put together a process where a patient can come in. We can look at their lifestyle, look at their stressors, look at their triggers, try to identify things that we can approach from a multimodality or a multi-specialty type aspect, in that someone may need a medication that they can take orally. Someone may need to have that in conjunction with some injections that Dr. Asghar can do around the nerves of the head. They may need to get a neuropsych evaluation, find those stressors, and then get some counseling to help deal with that. So we try to address the whole person, what we called at Georgetown Cura Personalis. Okay.
Now you transition nicely as well into my next subject over here reading over my shoulder. But I think, until I really got into neuroscience, I didn't understand at all about a headache. I thought a headache was a headache was a headache. Now I know there are various different types of headaches. So I want to first again touch on the different types of headaches. A headache, a migraine, a tension headache, a cluster headache. What are all of these things?
Well, you're giving me a headache, Pat. There are books, literally books written on headache and headache classification. And the basic distinction to make is this a primary headache problem? Is this a secondary headache problem? Secondary headache meaning this is due to something bad going on in the head. Most headaches are not that. Everybody who has headache is afraid they have a brain tumor or they have an aneurysm. Okay, that's a very small number. The majority of people that we see have migraine, and there are various kinds of migraine. You have your classic migraine, where people see the flashing lights and then they get an intense headache that may be one-sided, both-sided, may be nauseated, may vomit, they may not. They may just have sound and light sensitivity. But there are certain International Headache Society criteria that need to be met for a migraine. Sinus headache. Sinus headache is probably one of my pet peeves, I guess I'll say. Everybody thinks they have sinus headache. Why? Because it hurts right here. Okay? But yes, your sinuses are here. What nerve innervates the sinuses? The trigeminal nerve. The trigeminal nerve is the same exact nerve which is implicated in migraine, so that you get referred pain. People who have a heart attack and start getting pain in the left side of the arm, okay, that's not arm pain, that's heart pain, it's referred. This is referred pain into the sinuses from migraine. So we kind of touched on the classic migraine. A common migraine is the exact same thing. moderate to severe pain, unilateral or bilateral, one or both sides of the head with those other associated symptoms, but you don't get the aura, you don't get flashing lights. A tension type headache is that common headache that we all get, the one that I was complaining about before we went on, because I'm sitting here in front of the electronic medical record all day with my head bent over. It's just this kind of dull, achy, bothersome headache. You can continue on. And one of the other headache syndromes that we see a lot of, and I think is worth discussing, is chronic daily headache.
Okay.
There are people who come in and it's, and we try to determine how frequent the headaches are, and I have a headache every day. When you look into that, there are some causes. One is all of the medicines you see in Walgreens. Mm-hmm. Okay, it's counterintuitive. You get a headache, you take some Tylenol. You want the headache to go away. It doesn't, so you take some more, or it goes away and it comes back, so you take some more. If you take repeated doses of medicine, or any kind of pain medicine, it can be Tylenol, it can be Demerol. If you take it more than 2 to 3 times a week, it will drive that headache and keep it going. Mm-hmm. And a lot of times our advice to patients when they come in is you need to stop taking all the Excedrin, all of the Tylenol, all of the BCs, and you're going to have to withdraw from it. So that's a big thing that we see that is unrecognized a lot of times. Another thing is a secondary headache, so to speak, but not from something horrible bad, but from untreated obstructive sleep apnea. People who have chronic headache on awakening a lot of times have a sleep disorder where when you're asleep, you cut your breath off. The brain says, hey, I need some air, and it wakes you up to breathe. It doesn't wake you all the way up to be conscious, but it awakens you enough to take a breath. Because of that, you're chronically sleep deprived. That can cause memory trouble.
Exactly.
It causes chronic head pain. It's also an independent risk factor for stroke and for heart disease. And if you have symptoms suggestive of sleep apnea, you get tested, you're diagnosed, and then you treat that, the headaches get better as well. So it's not only just treating the headache that you have, it's trying to find out why. If it's migraine, we don't know why. It runs in families. Sometimes people get it for no reason, but we do look for an underlying reason and try to treat that. Okay.
We're going to take questions if anybody would like to call in the next few minutes, and the number again is 804-915-5202. And I'm going to ask Dr. Asghar, I'm going to get him with this gingerly question, since he's the newest on the block, and that is there a difference between presentation of headaches between men and women? And then I'll turn it over to Dr. Khawaja for my neuropsych evaluation.
Well, I think the typical features of head pain and headache are in my experience, similar between men and women, although women tend to have a higher frequency of migraine than men. I don't believe that they're much different between the two sexes, but I'd let Dr. Epps kind of.
Yeah, I agree. The presentation is about the same. Mm-hmm. Ladies do tend to get migraines more frequently than men. Men, on the other hand, tend to get a subset of migraines or a different class of migraine or a cousin of migraine called cluster headache. That's more common in men.
Right.
One thing, and I'm going to turf this to Dr. Khawaja, is I think sometimes, and people might start calling and yelling at me, but a lot of times I think the emotional response to the headache is greater in women, in that where the pain may be the same, the way it's perceived, and I'm going to slide away from you as I say that, is sometimes more dramatic with women than in men. And I think that's just inherent in our makeup. And what do you think about that?
Well, I think for anybody who's experiencing chronic pain and headaches related to it, it's going to have its emotional impact. And I think that kind of crosses the line regarding whether or not it's a gender issue or not. But I do think the clinical presentation may have something to do with that. But the fact of the matter is, what we see oftentimes is you'll be treating someone for chronic pain or headaches or migraines and things, and all the medical treatments are being done, but the headaches continue. Right. And the question is, well, like we were talking about earlier, depression, anxiety, other psychological stuff that happens with the fact that we're in pain impact the way that we A, experience pain, and B, increase the fact that we might have that pain again. So sometimes headaches, migraines may be treated very, very well, but the fact that we're very anxious and depressed about the fact that these things are happening increases the possibility that these things will happen again. And without an exam to further understand that, and if we can't address the emotional needs of a patient, regardless of gender, age, ethnicity, or those sorts of factors, we can really help and reduce the fact, the possibility that these things will happen again. And I think that's where these types of exams can really, really help, because anxiety is well known to increase the possibility of migraine, cluster headaches, tension headaches, and all the other things that we're talking about.
Stress is a big trigger, and I call it the migraine angst, which is probably you have your lifestyle affected by the fact that you get a headache and you have to not participate in family activities, or you may not be able to work. So that affects your lifestyle. But then when you don't have a headache, it's also affected because you have this angst. I've got the ballet recital tomorrow night and the PTA meeting. I hope I don't get a migraine. It's always in the back of your mind, and trying to deal with that angst, I think, is important as well.
No, I think you're exactly right. When we identify those factors, people who have those types of headaches will tend to reduce the amount of activities that they do because of the fear of this is going to happen again, and what if it happens in public? What if all of a sudden I'm in a movie theater or I'm out shopping with my family and this is going to happen? That person might say, well, I'm just not going to go out. And unfortunately, while that might solve the problem in the short end, in the long term, it's going to increase the possibility that these things will happen over and over again.
Well, we're in the month of September, which is the start of fall and autumn, and it truly is my favorite year. But for many of us, that means football. And one of the things that I think of when I think of football, unfortunately now today, is post-concussion syndrome, also known as post-concussive syndrome, or PCS. I'm going to date myself. In my term in school, when I went to school, I think they used to call it shell shock back in the day. So I'm going to ask, we have a caller. Let's see. Hello, welcome to our show for Neuroscience. How can we help you?
Yes, good evening. How y'all doing tonight?
We're good. How are you?
Thank you.
Oh, fine. I have a question to ask. I had to have an emergency operation in 2003 on my spine because my my spine was being cut into by my disc, and so it was almost cut in half. And ever since then, all the doctors do is fill you up with prescription drugs. Now, after a certain time of being on drugs, it starts to affect your head. It starts to affect a lot of things. My thing is, why do y'all continually keep pumping drugs into people's systems and not going back to natural stuff? Okay? I don't understand that. Here you got a state that has, back in 1979, legalized medical marijuana for glaucoma first and certain cancers.
Yeah.
Yet you can't get it.
So,
Since then, they have legalized it for pain. You still can't get it. Now you have your vets that can get it. The veterans can get it.
Yeah.
You even have two gardens. I'm sorry, not two gardens, but you have several gardens here in the state of Virginia, which are regulated by the Congress.
So I guess the question
of marijuana.
Right.
Yet people who are in pain can't get any natural stuff.
Right. And so I guess the question, as I understand it, is that you're wondering why we don't use marijuana?
Money on drugs that y'all are putting chemicals in there. You're using opium from other countries.
So,
all these other things, but y'all don't really get into it, and I'm still in pain.
Right.
So, caller, we're trying to get your question. I think Dr. Epps wants to know the gist of your question is, how do we start? And I think Dr. Asghar may have started with that on the treatment plan for someone.
Sure. Yeah. So I think it's a good question.
I'll hang up and listen.
Okay.
Great.
Well,
Thanks.
I sympathize with your problem, and this is something that is my focus now. There's two different issues here. The first issue is people being in chronic pain from an injury or what sounds like you had spinal stenosis from herniated disc pinching the spinal cord. And there's some people have chronic pain after that, and I do agree actually strongly that we should minimize any pain pills and narcotics, as they only help for a little while and then you get used to it, and then we keep going up and up and up, and no one really gets any better. Where I try to fit in is helping patients with minimally invasive procedures to treat the source of the pain if possible, and not drugging you up. So that's where I would try to fit into the picture. But I think with respect to going to totally natural pain relievers, and I think you're alluding to marijuana basically, it's not legal in most states to take marijuana, and it sounds like more of a congressional issue than a physician local issue, and that's something that we have no control over. However, if you were to live in certain areas and that was legal, then and if that's something you wanted to do, then as long as it's legal, there's probably nothing wrong with that.
I want to
go ahead.
No, I was just going to ask, because we do see sometimes people self-medicate with legal substances. There are people who drink because they're in pain. I mean, that's not an appropriate treatment either.
Sure, right.
So even if it was legal, it doesn't mean that it's necessarily medically appropriate. So.
And in addition to that, like I was talking about earlier, there is a psychological component to pain. And a lot of the things that I think, ma'am, you were talking about over the phone is the fact that the pain keeps on coming, and we're upping the doses of pain medication over and over again. And I would argue that there is likely to be a very strong psychological component to that particular pain. And there are numerous natural treatments involving psychotherapy and other things, and pain management techniques and things like that are readily available right here in Virginia. In fact, Richmond is a great market for those sorts of things. There's lots of pain management specialists who deal in holistic care and also in the psychotherapy and the mental health aspect of pain. Remember that whenever we can improve emotional status, we reduce pain. And we can do it very naturally with talk therapy, which I think is quite holistic in many ways.
Right. Yeah. Would biofeedback fit in there?
Biofeedback would be a great example of managing pain. And there are numerous individuals and providers in this community who provide that sort of level of care. So I think that there are definitely options out there that meet what you're talking about, and also coordinate with the best practice of medicine, which is what we're trying to do.
Okay. Thank you, caller.
Thanks.
I want to get back on to concussion syndrome, and I'm going to ask Dr. Asghar, what is concussion syndrome? What's going on?
Sure. So we're all kind of generally familiar with concussion, and concussion would be a mild traumatic brain injury. Most typically, we talk about it in relation to football, but also car accidents, and where someone hits their head, or a fall where you might hit your head, and I think we have to understand, or we understand that it's not necessarily related to loss of consciousness. Maybe there is a loss of consciousness, maybe there isn't, in terms of the symptoms somebody has. And in terms of symptoms patients have for concussion or post-concussion, I believe most people tend to get better within a few days, maybe a week or 2 weeks after their symptom, after the actual injury. And they may have lingering symptoms for up to a few months, and uncommonly, I don't think too commonly, up to a year. The majority of patients tend to get better earlier on. In terms of the actual symptoms, patients, we'll see patients after a couple of months, and they'll say, well, I hit my head and I'm not thinking right, I have headaches, I'm confused, I don't, I get aggravated easily, and it's something that definitely bothers the family and the patient too. So,
And I was going to say, Dr. Khawaja, I know you could go on forever for this. If
We
you could
could.
talk about some of the testing and traumatic brain. I mean, that's your world. You do a lot with that. If you can share some of that
Sure.
with us, that'd be great.
We see a lot of teenagers, adults, like you were talking about, sports-related injuries, car accidents, things like that, where they'll present in the emergency room and the MRI is normal, the CT scan is normal, the neurologic exam is normal, and the patient or the family say, you know what, something is different about me, or something is different about this person. They're not thinking as well, or they're not processing things as well, or they're not concentrating as well, or like you mentioned, there's a change in mood or personality, and these things are very, very common in mild traumatic brain injury. Sometimes neuropsych testing can be one of the only ways to determine, A, was there evidence of such an injury, and if so, what's going on? Where is the specific area or areas of deficit so that we can do something to help improve their functioning, and in addition to that, reduce the time of recovery. And so a lot of times I will see folks, who have sustained a football injury or a hockey injury, or they get into a car accident or something like that, and the exams are negative, but they come in and we do identify that there are some deficits here, there, or the other, and then we can treat those things to help them get back to work, get back to school, get back to playing sports if that's what they desire, etc. If there's a mood-related issue, we can get those things in place early, because the key thing with brain injury of any kind is the earlier the intervention, the better off, the better the prognosis is.
Yeah.
So you're talking about a year, 18 months, things like that. If we can identify those things very, very early, which we can with our testing, we can really improve the prognosis of this may get better. You can go back to work, or you might be able to go back to school, or if you have to go back to school, here are some accommodations that we might need to have in place for you in school in order to make sure that that person is successful and as emotionally healthy as they can be.
Mm-hmm. And Dr. Epps, I want you to discuss your personal experience, because I know you have a son who plays, and thank goodness I don't have any boys, because I'd be like, I don't know, but I love to go to the games and yell for people. What preventive mechanisms have you talked to your son about and worked with the team? And I know there are a lot of mothers out there that are thinking about that and being like, oh, my baby.
Well, I tell you, my son plays football for Benedictine, go Cadets, and my daughter runs track for St. Gertrude, go Gators. So the thing, though, is that the sport and the recognition of concussion and the treatment of concussion and the prevention of further injury has come so far than when it was, again, you got your bell rung, you got up and you got back out there, okay? Now, if you look at the helmet design these days, the helmets are much more efficient in terms of absorbing shock. They are exquisitely fitted to the player's head, to the extent that we were discussing earlier, when two-a-days started in the summer. At Benedictine, of course, it's a military school, so you have a military haircut. Coach was very adamant that the players have their military haircut, because that would affect the fitting of the helmet. Right. Each player's helmet is fitted to that player's head. There are air balloons in there. They are much better than they used to be. Also, the teams at all schools, this just isn't Benedictine and St. Gertrude, they have concussion policies. Right. There are trainers that are on the field that are trained to recognize symptoms of concussion. They have team docs. And, it's important that it used to be, back in the day, coach made the decision if you went back in. Now, the trainer or the team doc makes that decision. So that if you have a grade 1 concussion, which is getting your bell rung, there's a specific sideline testing protocol that needs to be followed, and if you pass that, then you can get back in the game. If you have a grade 2 concussion or grade 3, you don't go back in that day, and you have to follow a certain set of standards. There is pre- and post-season testing. You get tested at the beginning of the season. I'll let you take that call.
I'm sure I knew it was going to happen. Hello, Carl. How are you?
I'm fine. I'm very informative show. I'd like to thank you for coming on.
Thank you.
Thank you.
The question about migraines. Are there any foods or drink that treat a migraine? And I'll hang up. Thank you.
Thank you.
Thanks.
Foods for migraine.
So some people have chocolate or wine that can trigger a migraine. I think, lack of sleep triggers a migraine. I think those are the most common triggers. Would you?
Yeah, it's different for different people. Right. There used to be the whole thing about MSG and Chinese food, or remember the accent, the flavor enhancer. That's simply MSG. Some people are sensitive. Hard cheeses, Parmesan, Romano, some are triggers. And there was a time where we would take people off all of these foods, and we would say, okay, get rid of chocolate, get rid of alcohol, get rid of cheese, and then reintroduce us processed meats with nitrites, hot dogs, bacon. You can't do that these days because we're so busy. You're running, you grab something to eat, you get something for the kids, taking them to practice. So what we typically say now is look for something that could potentially trigger. You go to a dinner party and you have a glass of red wine. You typically don't have red wine. You drink white, and then you get a migraine. Well, it could be the red wine. Could be dark liquor versus clear liquor. It could be the chocolate that someone brought into the office. So it's really just a matter of recognizing what you did prior to having the migraine and tracking it with headaches. I mean, I know I do it all the time. I'm sure it's part of what we do.
Yeah,
keeping a log.
Keep the log of the headaches. When did they happen? How long did they last? What did you do preceding? So then that way you can identify it. For ladies, the menstrual related or the hormonal related migraines are a big factor, and I have my lady patients track not only their headaches but their period. So then that way we can see if there's a correlation. So that's another big trigger. But hopefully that helped.
Thank you, Carla. That was a great question. I was going to ask you about the logs. I think that's a really good thing to do. Is there anything else you all want to say on the concussion syndrome? Because preventive, and I know, just what would you tell somebody if they came into you, if it was, I said your grade 3 or whatever, for neurology, and if they're young, what parent instructions? I remember keeping people up, and
a grade 3 concussion is basically a concussion where you lose consciousness for more than seconds, basically. So it's loss of consciousness for minutes. And those patients, those players, it could be basketball, it could be football, it could be falling on the track doing hurdles. I mean, it doesn't matter. It could be slipping and hitting your head, falling down the stairs. We always associate it with sports, but you can get a concussion from other things. If you have a loss of consciousness, you need to be evaluated in the hospital. So you need to go to the emergency room. You need to have a good neurologic examination. You need to have a head scan. If those things are normal and you are back to your baseline level of functioning, you can go home and follow up as an outpatient, and typically things get better. If they're not, then you need to be observed.
Hi, caller.
Yeah. So really what you're saying is that y'all really don't deal with permanent injury because nerves don't grow back. And what y'all discussing here is things that can get better. But the pain I'm talking about, the nerves were damaged to the point where it's no such thing as getting better unless y'all can transfer some nerves or something. And another question I wanted to ask also was, have y'all ever had any injury whatsoever? I'll hang up right now.
Okay, I'm gonna also tell you, caller, let me see, in 2 weeks, our third show is gonna be specifically on spine injury. So you might want to call back for that one because we're going to have more experts. I'm not going to say more experts, but that's some of their specialty is specifically in spine. So call back on that as well. I don't know if you all have anything brief that you want to tell the caller, or you can also call or go to our website or call that number that I said, 359-WELL. And send me any questions and I will field it for you. I think we have like 10 more minutes and I really want to get to something that's not on our program, but while we have the experts, I wanted Dr. Khawaja to talk a little bit about Alzheimer's and dementia because as November comes up, that is Alzheimer's month, and that's something that I know the community would like to get some pearls of wisdom from.
Sure. I think one of the biggest stresses that families have and individuals have is as we get older, are these senior moments that we have, are they normal for our age or are they not normal for our age? We might misplace our keys, or we might repeat ourselves every now and again, or we might get lost on the way to the grocery store. And the question starts to pop up, is there something wrong with me, or is my mother, my father, or myself, are we just having a senior moment? And the issue with identification of dementia is that, like I was talking about earlier, the earlier you can catch it, the more that there are more things that we can do about it. And the longer that we wait and excuse these senior moments, or whatever you might want to call them, the more trouble we get into in terms of, can we stop or at least slow down the progression of this disease? And one of the things that I see when I talk to a lot of patients is the family will say, well, this has been going on for 5 or 7 years, and we just never wanted to talk about it because it was uncomfortable, because the person who was showing these problems was very resistant to the idea that there might be something going on, and we were all just excusing those things. And for us, I think that's one of the more frustrating aspects of treating dementias, is that we have to wait so long for people to come in. And I think part of the community awareness is there's no harm in getting tested. These tests involve no needles, no offense to you. No electrodes, no offense to you. I mean, these are very simple paper and pencil tests in a very relaxed environment. There's some computer testing that goes on. It's not invasive at all. We try to be very friendly at doing what we do. But we can target and identify these things well before they might show up on a traditional neurologic exam. And there's some things that we can do to help neurology say, okay, I think we're seeing early signs of dementia. In addition to that, there's the problem of pseudo-dementia, which is when an older adult is showing signs of depression, but those signs are manifested as short-term memory loss, a decrease in attention and concentration. Families like, I have to repeat myself to you all the time, or I don't trust you with your medications, or this, that, and the other. And one of the only ways to delineate what's the difference between those two things, is this person depressed when they're not feeling depressed, versus is this a sign of early dementia, early Alzheimer's, or some other neurologic issue, is by doing these specific tests, because we're able to, as best as we can, delineate between the two. And of course, the treatment for depression is radically different than the treatment for dementia. And I've seen many patients who come in and they look like they have profound Alzheimer's disease, and upon evaluation it comes back, oh no, this is a pseudo-dementia. We treat the depression and those memory issues get better. So I think either way, it's a good idea to think about, when we start approaching the age of 65, around that particular time, to have some tests done. They're relatively benign, and at least you get, one, the peace of mind of knowing that there's nothing wrong, and B, if there is something wrong, if we identify it earlier, there's a lot more that we can do about it as a comprehensive care team to help. And I think either way, that patient and the family is in a better place, because one of the things that I always say is that knowledge is power. The more that we know about something, the more we can do about it. And it causes a lot of anxiety in families and the patients to worry, is there something going on? I'm afraid to ask that question. And my response is, that fear is not worth not getting tested.
Thanks for that. I can't believe I was almost gone. I want to ask Dr. Asghar if there's anything you really want the community to know that you want to stress today, if you can give us like a 1-minute spiel, and then I'm going to give you an assignment, Dr. Khawaja, while you're here to talk about attention deficit disorder, if you can do that.
Sure. Okay, 1 minute. So, my interest is in helping people with pain, chronic pain, and, down that road. So I guess really, the best thing to do is, we try conservative treatments to begin with. Definitely, keep in touch with your primary doctor. Try physical therapy. Try stretching. Try, to check and see if there's any mood component. All of these things impact your pain. And if those things aren't helping, then ask for a referral to somebody who specializes in pain, and we can kind of walk you down a pathway where we may be able to help reduce the pain and get you back to better function. We could try doing non-invasive things like TENS unit, send you to therapy. If that's not working out, we can do some minimally invasive injections, back pain, neck pain, and those things tend to get people back on the road to recovery, and at least to where they can function and go about their normal life. But as a whole, we just want to help you get better and back to your function, and that's kind of, I think, where we're coming from.
Thank you for that, Dr. Khawaja.
You were asking about ADD?
Yeah, I wanted to try to get it in if you can.
Yeah, I did forget. Okay. In Virginia and in the nation as a whole, there are many, many children and adolescents that are taking medications for ADD and ADHD, and most of those children or adolescents never got tested. And in my experience, most of those children or adolescents don't have ADD or ADHD, but they presented, or the family presented to the primary care saying, hey, look, my child, the teachers are saying my child's not focusing and paying attention in school. They are bouncing all over the place, or an adult will say, I'm having difficulty with focus, attention, and concentration. They will, fill out a questionnaire or two and talk to the primary care, and the primary care may prescribe and say, well, here, try this medication because it might help. Well, ADD and ADHD medications work for anybody. Anyone who takes that medication is going to improve their focus and their concentration. My concern is with children and adolescents is here we are introducing a chemical into a developing brain where that child or adolescent may or may not have that condition. Meaning ADD or ADHD is a medical issue. That's a sign that there's something going on in the frontal lobes of the brain that is causing an impact in terms of behavior. Many, many times there's some other issue that's causing the problem, be that an emotional problem, be that something going on in the family or some other issue, and we have this very high level of over-medicated children, and that's very, very concerning to me because that impacts the way the rest of their lives are going to turn out. Mm-hmm. And that's where testing can be very, very, very helpful, especially even in cases of mild traumatic brain injury and things like that. A lot of times we'll see a difference in attention, concentration, and in focus. But without doing the testing, we don't really know why that's happening. And that's where I think that's a reason where neuropsych can really, really help.
Okay. Thank you for that. And we're going to make sure callers, and if you want to go to our website, www.bondsecours.com, you can look for neuroscience and neuropsychology, and we can be able to help you with that. Or you can contact me at patricia_lane@bshe.org, and we'll have that for the next 6 weeks so you can be able to funnel. Dr. Epps, you want to tell us a little bit about your offices again so we know how to get in contact with you, and then give us your last words, and I'll talk about the series.
Sure. Well, I'd just like to, again, thank you for having us tonight. Thank everyone for watching, for calling and participating. The Bon Secours Medical Group Neurology Clinics, we are located on Iron Bridge Road in Chester. We have an office at the Watkins Center, which will be open on October 15th. Within that office, we will have an embedded neurodiagnostic lab, including autonomic nervous system testing, tilt table testing, carotid Doppler, EEG, EMG. Imaging is right downstairs with CT and MRI. We have a brand new practice that will be opening at Memorial Regional Medical Center on October 1st. That's in Medical Office Building 1 on the 3rd floor, Suite 305, I believe. But our office number can get you in contact with them. That's 285-6880. And again, if you're having, I guess my personal message to you is if you are having something that seems to be neurologic, if you're having chronic headaches, if you're having chronic pain, if you're having trouble with memory or concentration, if you are having epilepsy or you have epilepsy and have continued seizures and you need help getting control of that, any type of neurologic issue, talk to your primary doctor first, and by all means we'd be happy to see you, so ask for a referral.
So callers, we've really enjoyed the panel, and like I said, we have a 6-week series. This was our first. Next week we will be doing Bon Secours and talking about brain tumors with the Color Center. And then the next week we will be doing spine, minimally invasive spine, and how you treat that. Then we will go into kind of a 2 segue on stroke risk factors, and then how do you treat stroke? It's very different these days. And then we'll wrap up with epilepsy. So we are very excited to have you learn with us about neuroscience. I think it's fascinating, of course, that's my love, and I think all of the panel's love up here. Bon Secours is someone who really believes in giving good help to those in need, so certainly feel free to come to us so that we can be able to guide you to a healthier lifestyle. And as I said, we look forward to seeing you. If you go on our website, we do have the series listed so that you can be able to get in touch with us to have a better neuroscience life. Again, thank you for coming to our show today, and we are actually going to put this on our website in case you would like to. Thanks so much, and have a good night.
Thank you.
Good night.
still have it. So I still. Oh, okay. All right. That wasn't bad. Wasn't as painful.